Welcome back. Our next session is titled Implicit Bias versus Explicit Bias. It will be moderated by Ms. Rita Higgins, RN. Ms. Higgins is the parent of a young adult living with CHD, an experienced advocate and speaker. Please join me in welcoming Rita, who will introduce the session and then her panelists. Hi, Rita.
Hello, thank you, Rebecca. I appreciate that. Hold on just one second. Can you hear me okay?
Yes.
All right, just making sure. All right, I'm so happy to be back with Conquering CHD for these vital conversations. Thank you for everyone for spending your time with us today. Way back in 2002, I had no idea that the color of my skin could affect healthcare. And unfortunately, some assumptions that my primary physician had made about me led to me delivering my daughter at an understaffed and underfunded hospital. Trinity was actually born with what they referred to as breathing issues. She was kept a couple of extra days in the hospital and then sent home. And I wasn't a nurse back then, so I didn't know the words to use, but something just didn't feel right to me. And I tried to bring up these concerns, but because the understaffed and underfunded hospital said that she was okay, my concerns were brushed off. And fast forward 2 months later, by the time she was diagnosed, she was already in heart failure. She ended up having to have the first of 3 surgeries when she was 4 months old. So I really want to thank you, Conquering CHD, for really highlighting the issues that still exist in healthcare today. We are going to be spending some time exploring implicit and explicit bias and how they manifest in healthcare, both on an individual and system level. Different types of bias, whether it be racial, age, family status, socioeconomic, and then also how that plays into hospital staff and culture. I have got an excellent and amazing set of panelists with us here today, and I am going to introduce them one by one. Dr. Kiona Allen is an attending physician in the pediatric cardiology unit at Lurie Children's Hospital in Chicago. She is also the medical director of the cardiac care unit, the single ventricle, say that twice, Center of Excellence, and the associate medical director of the NICU Cardiac Neurodevelopment Program. Dr. Allen is also an assistant professor of pediatrics at Northwestern University's Feinberg School of Medicine. Next, we have Miss Belen Altuve. She is an adult with CHD living in Jacksonville, Florida. She was born in Venezuela and is passionate about the advocacy of children with congenital heart defects. And she is actually also the founder of the nonprofit organization, and I'm going to really make sure that I try to pronounce this correctly, the Fundación Estrellita de Belén. And that also means the Little Star of Bethlehem. Next, we have Dr. Sal Gende, and he is an adult congenital cardiac specialist at Children's Wisconsin. Go Children's, that's my home territory. And the director of the multidisciplinary Fontan Survivorship and Advanced Therapies Program. He is an active researcher and also serves as an associate professor in the Division of Cardiovascular Medicine at the Medical College of Wisconsin. Next, we have Dr. Veronica Gunn, and she is a board certified pediatrician and CEO at Genesis Health Consulting. Throughout her career, Dr. Gunn has worked to improve health for children and families. She holds more than 20 years experience in clinical practice, research, and healthcare administration. Dr. Gunn's unique perspective on systems-based approaches to sustainability, improving health, makes her a frequently invited speaker and at clinical and policy conferences around the world. We have next on the panel is Miss Tori Smith, and Tori is the mother of 6 and lives in Rockford, Illinois. 2 of her sons, I'm sorry, I lost my place here. 2 of her sons are living with CHD, and she did lose a child to CHD in 2011. She continues her son's memory with advocacy at both the local and national levels, including working with Baby's First Test. Tori is a passionate advocate for foster and adopted children, especially highlighting the disparities that they face. And last but not least, we have Dr. Chante Williams. She is the Associate Director of Biomarker Discovery and Development at Hematogenics. She is the parent of a child living with CHD and lives with her family in Chicago, Illinois. Dr. Williams is an experienced advocate on both the local and national level and provides expertise in health disparities as a speaker at several conferences. So as you can see, we have a lot of experience and a lot of perspective on our panel today, and I'm very appreciative of everyone spending your time with me. With that, I'm going to go ahead and jump in with our first question. And it really deals with some of the differences when we talk about explicit versus implicit bias. And I sort of always feel like explicit bias is very easy to pick out. It's because someone has made a conscious decision to do something or act in a way because of something about someone else. But implicit bias can be a little bit of a difficult subject because people don't always realize that they have it. So I'm just going to throw out the question of what does the term implicit bias mean to you? And Chante, I'm actually going to ask you to address this first, and then after Chante goes, we can sort of flow into some discussion about that. But tell us a little bit about that, Chante.
Okay, thank you very much, and thank you for allowing me to speak today, because we know that bias comes in many forms: race, gender, physical attributes. However, my experience of bias is highlighted as being a Black American. And when we use the term implicit bias to describe when we have attitudes towards people or associate stereotypes with them without our conscious knowledge, that is implicit bias. I mean, you don't know that you are doing it. And that is so important today. And it is important because in order to really dissect implicit bias, you really have to take a good look within yourself. And so today we've heard a lot of terms, or we've heard the terms race, ethnicity, those social constructs, the idea that has been created and accepted by people in society. But one of the terms that is important to understand when we're talking about implicit bias is lineage. And the reason lineage is important because it connects you to a lived historical experience. So for example, when I say I am a Black American of enslaved people, the lineage there allows me to connect my current conditions and experiences to history. So what does that allow me to do? It allows me to be able to embrace the validity of the feelings that I have, or that Black Americans have, of the mistrust of healthcare providers, the mistrust of medicine, the feeling of insignificance, or whether you are being, your validation there. So a lot of times you may say, or you may be thinking, when we talk about that piece of history and understanding history and going back to that point, that was such a long time ago. So what is the relevance of that today? So I would say, and what I do say is that it's very important, because if we focus in on understanding the true essence of who we are, our actions will follow. And we're able to embrace and really highlight those implicit biases that are within us that we don't even know that we have.
Very good, thank you. I appreciate that. Tori, I know we actually talked for quite a while earlier this morning, so good to see your smiling face on camera. Can you just sort of speak to some of your experiences? I think that, and you can, obviously feel free to tell as much about your background as you want, but we talked earlier today about, you have a family that is made up of lots of different races, and some of the differences that you've actually noticed in the way that some of your children are actually treated. Can you just sort of tell us about some of your experiences in healthcare? I really just want to sort of highlight this, because one of the things we talked about earlier is when you've never been in the situation to be the receiver, it's hard for people to grasp sometimes that these things actually do happen and are still happening.
Yes. So I actually have 7 children. I did another one this last summer, but and he's actually my only white child. So it's kind of odd for me too, but it incorporates that, seeing the absolute difference that his treatment gets versus my other kids. But my oldest son, when he was 4, I noticed he was kind of breathing funny. He is mixed, but he looks white. When I called the pediatrician and told her, I think he's breathing funny when he's sleeping, I'm a little concerned, we were brought in immediately, radiology, sent to all things, and he was 4, and we found out he had a heart defect at that point and like some blood pressure issues, and that was what was going on. And it happened so fast, and he wasn't even like, he just was breathing a little funny. He wasn't in distress or anything like that, but it just very quickly, we got what we needed for him. Fast forward like 2-3 years later, when Sterling was born, right away. So when I brought him home from the hospital as a newborn, and he had no prenatal care, there was drug and alcohol use, which we know the drugs that she chose can cause heart defects, and alcohol certainly causes heart defects. And he immediately started, like, when I brought him home, not eating right, struggling to like breathe, eat, and do all these things. And he would get sick, and it would last weeks. And I would bring those concerns up to the doctor, and I would get brushed aside. And I don't know if I said this, but he is full Black. So like, there's no question that he's anything but Black. And she very, pushed every concern aside, told me he looks fine. Even the week before he died, he was seeing a doctor for an undescended testicle, and his stomach had been distended. His coloring to me looked different. I mentioned these things repeatedly, and I was told, that Black children, their colors change. You just don't know what their color changes. He could just be chunking up because his face looked puffy, all these things. And that wasn't it, because he stopped breathing exactly a week later after I was told those things for the last time. And we found out on autopsy that he had multiple congenital heart defects. So that kind of keeps me going like into this stuff, because I really feel like in a lot of the stuff, I still see that, we talk a lot about blue babies, but African-Americans don't look blue. His coloring was different, and I knew something was wrong with it because I see him every day. It was a different color than what he should have been. And I was completely brushed aside, and he is now dead because of nobody listened to me. Nobody, and I think we talked a lot about that. And I also have the 3, so Sterling, Silas, and Sawyer. Sawyer we knew was born with a heart defect, and then they didn't check Sterling, and when Sterling died, they wouldn't check Silas either. They kept telling me he looked fine. It took me like almost 1.5 years to get him. So a lot of the stuff that I do too right now is that, when children are foster and adopted, there's a lot of things that we don't know. And why are we not testing them? Why are we not looking into that further? What are the things there that clearly, in foster care, the majority of the children are Black. They're highly overrepresented in foster care, and yet we don't test them. We don't do all these things that we should do, and they have really, I wish I could say that I was the only foster and adoptive parent that this has happened to, but I'm not. This happens a lot of times. We say it's SIDS, or we say it's not necessarily true. So
yeah, I was just going to add that I think what's really hard about these conversations is that it's really tempting for us as providers to think of what you just described as a thing someone else would do that we can't imagine doing. No matter what your race and ethnicity is, as a provider, as a healthcare provider, as a doctor, I think that is what's so hard about implicit bias, explicit bias. I think judging by the fact that you're on a health disparities advocacy call on this fine Sunday, like I'm pretty sure that most of the people on this call have or would like to have a low level of explicit bias. And I think part of the problem that we have in this group is that the idea that we could have implicit bias that would allow us to behave in the way that you're describing is so painful for us conceptually that we are not honest with ourselves about the fact that it is not something that we are doing on purpose. It's not something that means you're a bad person per se. It's something that we've been trained to do from the time that we were very little. And in particular in medicine, where we have to make snap judgments about things all the time. You can't work through the 27-page differential diagnosis for a problem, like step by step, every single time you have to make a medical decision. We lump things together. We make snap judgments based on our prior experiences. That's how we function in medicine. So we are actually more of a setup for this problem than the general population. And the problem is that because it feels horrible to think that we could be participating in this, we are not being honest enough with ourselves about how to stop and take stock of that and to deal with it the way it needs to be dealt with.
I think that's a good point, because I think instead of just taking implicit bias and dissecting that, we associate that with a negative undertone as, oh, I may be considered as racist or discriminatory. And really, it's again about just looking within yourself and then correcting at that time. It's like, why am I feeling this way, and why did this happen? You know, so I agree.
Yeah, in one of my past roles, I used to investigate safety events, and those are when things don't go quite as we planned in someone's care. And whenever I was investigating those, I'd always start off with saying, none of us probably woke up this morning and said, I'm going to make a decision that is going to directly harm someone. And you're so right. That's what makes this difficult to deal with, because it's not something that you can pinpoint to say you purposely made this decision. And when we don't purposely do something, we immediately get very defensive when we have to maybe sort of own up to some of those things. So I think that is a really important part of exploring bias, is reducing that negative stigma that exists when we're talking about implicit bias. So thank you for putting that in. Does anyone else want to add anything to that particular topic before we move on to our next question?
Yeah, I'll just add, thanks, Rita. Again, thanks to the organizers for setting up this panel and inviting me. As a provider, I agree completely with Kiona and these pitfalls within our medical system. And as providers, it's really challenging. I think specifically in the field of congenital heart disease, I think one of the challenges, it's so hard to measure implicit bias and unconscious bias among providers. It's in our field, just even before the last few decades, there really was no standard of care that we could follow. There was no guidelines. So there was just tremendous variation in care across all the centers with various types of congenital heart disease. And just within the past few decades, we now have very specific guidelines and recommendations about the type of care that patients should receive at all ages, what medicines to be on, when to refer for interventions. And so now we can go back and see which populations are not getting really the standard of care that they should be getting. And that as providers is really important. It impacts the quality of care that we give for our families and our patients. And so I'm glad we're talking about this topic. I think it fits in really nicely with the previous discussion about barriers, not just in ACHD care, but CHD in general. This is such an important barrier to providing quality standard care for our patients and families.
Thank you. So I think a couple of people actually already sort of talked about individual, levels of bias, but then of course, systems are made up of individuals. So inherently, it creates an environment where these biases creep into our systems. And how can we really identify biases that are being supported by at a systems level? I think you have these different layers. You have explicit biases, which are a little bit easier to address. Then you have these implicit biases, which are more difficult to address. But then even more so when they've crept into being supported by systems. So Veronica, with your background doing a lot of work at the systems level, can you sort of give us your take on how we can address these things and identify them when they're at the systems level?
Certainly, Rita, and thank you as well for coordinating this. And Tori, thank you for sharing your story. I am, like my other panelists, moved, and like Kiona said, horrified at the same time. You know, I like to consider myself an enlightened person, and as a woman of color, I have been on the receiving end of implicit and explicit biases in my work. And as Rita, as you said, systems are made up of humans. So we're all fallible, therefore systems are fallible. And let me share a story as an example of how this manifests in systems. When I started practicing, most of my clinical practice has been either in communities that are impoverished, and primarily within serving communities that are enrolled in Medicaid or uninsured populations. And early in my career, I recognized that there were some rooms that I was less comfortable entering, some patient families that I couldn't put my finger on it, but I just didn't feel as comfortable. I wasn't looking forward to going into seeing these patients. And I couldn't see what the common thread was across these families. And in fact, it wasn't until we went to dinner, frankly, with friends and went to visit the parents of these friends. They're a lovely couple. I genuinely like them. And on the drive home, my husband said, "Veronica, why don't you like them?" And it brought me up, you know, it made me stop. And I said, "What do you mean?" And he said, "Every time they started to talk, you shut down." And I did not realize this about myself, but I did then. What these families had in common is they were loud. They were effusive. They were warm and boisterous. They talked with their hands. And this particular couple over dinner, actually the family, they frankly yelled at each other, not in anger, but in a very loving, over-the-top way. And that intimidated me. That style of engagement made me uncomfortable. And I realized those are the families whose rooms I was less comfortable entering. It was not what they were saying, it was how it was being communicated. How might this manifest in systems, though? I have been in any number of health systems and clinic settings where you see families, and often this tends to be families of color or families for whom English is not their first language, who are animated and characterized as angry or threatening or a safety risk. Similarly, I have sat in the lobbies of many a health system and simply watched families as they are greeted. And many times, I encourage you all to do this within your own settings. Just watch how families who come in who are loud or boisterous many times tend to be greeted by security more than they are the volunteers at the front desk. Do I think that is intentional? No, I think it is indicative of implicit bias within systems. And so how can it, if it is implicit, if it is unconscious, as Dr. Williams pointed out, how on earth then are we to surface something that is unconscious? And I would say there are really two different steps that are in an oversimplified way that we can think about this. The first is to be intentional. I mean, like all of us as individuals, we have to be intentional in reflecting on what, when I feel this way, when I'm walking into a patient room, why is that? The same thing for systems. So if as a system, you look at your practices and find that the outcomes of those practices seem out of proportion to the families that you are serving. So for example, if you were to look at the families in your systems that have risk assessments associated with them are disproportionately reflected among Black and brown families, that may be indicative of implicit bias within your system. If the babies born to women of color, or babies born to women who are unmarried, or babies born to women who are in urban or rural areas more than suburban areas, are screened for intrauterine drug exposure more often than babies who are not, you may have indications of implicit bias in your system. Do you screen for women of color, of intimate partner violence more often among women of color? So looking at your processes, your practices as systems, as practices, as clinicians, and seeing if what you are doing is resulting in a very different outcome amongst your patients, it may be indicative of implicit bias. And then the second thing that you can do is actually talk to your patients. Your patient families will tell you when they do not feel heard or when they feel judged. And many times they will tell you with their feet, which means they will leave, in which case, as clinicians, it's really incumbent upon us to make an effort to survey our families who are no longer with us and be prepared to listen for why that is.
Thank you. Yeah. One of the things I'm always going to try to do throughout this panel is have people walk away with tangible things that they can actually do, because, you know, it's one thing for us to sit here and talk about, you know, what is wrong, but it's a whole nother level to start identifying actual concrete things that we can do. So thank you for just talking through some of the things that systems can actually do now. Today doesn't require anything special for you to start looking at the way that those things are designed and the way that that data is showing up. So I appreciate that. Does anyone else have any thoughts on the systems level of biases to contribute?
I think that one of the things I find interesting as I watch from my perspective as a provider of color in the hospital is how different families approach their way navigating through those systems. So you can, as an individual family or as a staff member, for example, try on your own to get around some of those stereotypes and implicit biases. This is something that Chante and I have talked about a lot in that we know each other. I'm one of her son's doctors and have been for a long time. But I think a lot of times the families know that they're being seen this way, that they're being treated in a way that's different, that they're being judged, and they take concrete steps to get around that problem, to over compensate for it. So there's no question that, like, no, I'm not angry, I'm very pleasant. And, you know, there's a lot of talk now when we talk about race and bias about code switching meaning you sort of change your persona to get what you need from the majority culture. I think some of our families, particularly, well, actually not just families of color, but families as a whole, the hospital has its own culture. So there's Eurocentric white culture, and then there's also hospital culture, which is its own bizarre separate thing. And I think families who are very successful in the hospital often learn very quickly to code switch into that very grateful, sweet family who brings in cookies and donuts and is always present and pleasant and isn't angry. And it's sad that that has to happen for people to get what they want. It is also true that some families don't know to do that and shouldn't have to do it, but also just don't have the skill set or the knowledge that it's a thing they should be trying to do. And that, for sure, I have seen affect medical outcomes.
And if I could just add to that, that is, I am guilty of that. And I don't know if it's guilty or not, but it's more so, it's a conscious effort when we are inpatient to make sure that during rounds that I am present front and center, that I have my questions written out, that, you know, I am articulating a certain way to just ensure that the communication that I'm receiving back is that, hey, I care, I'm here, you know, I understand, you know, I look the part per se, just so that I can receive a certain level of treatment for not just my family, but also for Carter. And I like to just use one example. He was there, we were inpatient, and he was, the doctors came in, and there wasn't necessarily an acknowledgement. It was literally like I was looked straight through. And they went to talk, they were talking about Carter, and I, inserted myself there. I was like, okay, I got to make sure that, whatever they're talking about, I need to, let them know that they need to communicate that to me as well. And so the conversation was about the neurodevelopment aspects of congenital heart defects, and, what that entails, and what what studies are being done. And so then the doctor literally turns and says, don't worry, I know you used a lot of terms you really don't understand, but it's okay. And then that took me to that was a trigger for me. And it was a trigger, and and I had to speak up. But before I spoke up, I had to make sure that I articulated properly and not come off as angry or with an attitude. But I wanted it to be, said plainly that, I do follow you. And when I do not follow you, I will articulate that, and I will ask the question to explain further. But at that time, I don't know that the doctor, again, recognized that, that he said anything wrong. It was just like, okay, there's nothing to be alarmed about, but this is what we're discussing. But for me, it was a trigger. It was like letting me know that I didn't understand, I wasn't going to understand, and it wasn't worth the time to stop to explain that to me.
Well, and you have a PhD and, and speak English, right? I mean,
yes. Mm-hmm.
If these things happen to you, I think it's just so interesting to me, the perspective that you have as a highly educated person who you are brave enough and strong enough to stand up and insert yourself in that situation. How many times would the person in the room have just sat in the corner and been ignored and not had their questions answered?
Exactly. 100%. I've, we've been in a great room and heard these discussions, and just, they just don't know what questions to ask, or, taking the information that they're given, trying to decipher it themselves because they didn't know to say, I don't understand, so I definitely, agree.
Thank you. Yeah, definitely bringing back some memories of triggering, and for any healthcare providers that are in the audience, I think that's also a highlight, that when families have these negative types of interactions, those things get carried, forward, and they can sort of cloud future interactions. I just, even remember back when Trinity was going to have her first surgery. I had braids in my hair back then, and back then braids were very, people looked at them as, being very unprofessional, and, I think made some probably pretty quick judgments about your background if you, came in with braids. And I remember taking my braids out before she had that first surgery, because I was just very fearful of having anything play into the types of care that she received, or the types of assumptions that people made about me when it came to giving me information, or, having certain conversations with me. So thank you for highlighting that. We're gonna switch gears just a little bit, because I hate to say this, but my daughter is 19 now. She is off in college, and, as a parent, I've been the one navigating biases on her behalf for a long time. And, and I've tried to teach her how to advocate for herself, but, you have this age where they're not fully grown, but it's not like I can call up her physicians and have conversations, with them at this point. And so when thinking about just transitioning into adult care, and Dr. Ginde, I'm actually going to ask you to address this one first, and then, feel free for other folks to chime in. But how can young adults ensure that they are getting equitable care when it comes to, them having to make decisions and have these conversations on their own now that they're into adulthood?
Yeah, thanks for that question, Rita. I mean, you bring up a lot of good points, and that is, as we talked about in the previous panel, such a high risk age and time period. There's so many transitions going on as you finish high school, go on to college, and or start a job, take on more responsibilities, and now you're asking these young adults to take on more ownership and independence of their healthcare. And as you know, it doesn't happen, at one point in time when they turn 18 or when they transfer to an adult congenital provider. And so that process of self-care and self-advocacy has to start earlier in adolescence. And we heard a lot about transition programs and about trying to improve the knowledge that patients have about their health condition, understand, the plumbing of their heart, how things work, what are the residual issues that are there, what medicines they're on and why, and what are symptoms that they need to discuss with their provider if they come on, what are important things to look out for. And, at that age, there's also, as we're learning, a lot more issues, not just health related or medical related, there's psychosocial issues, emotional health is important, and then issues with, more health maintenance issues, discussions of birth control, pregnancy, exercise, diet. And so I think for your daughter's case, or for many young adults, I think having a strong knowledge base of what the heart condition is makes you more confident and strong so that you can advocate for yourself when you meet your provider and discuss, what the plan is, what are the long-term issues that we need to look out for, and what they can be doing to help improve their health. But it's a process that has to go on through multiple encounters, and making sure that there's an adequate transfer process from the pediatric provider to adult-centered care to help minimize the disparities that can happen with adult providers who are not trained and specialized in CHD, which can occur to an extent.
Thank you. Does anyone else have any input on that particular topic? One of the things that that Trinity, has asked me about is when is it too much for questioning? I think she's seen my concern over the years about how I sort of delicately approach questioning of should I get a second opinion here, or what does someone else think about this? And because she's also concerned about getting that treatment of, what do you know? You're only, 19, you're only 20, you haven't lived very much. And so it's interesting the fact that, sometimes these biases can exist in just all aspects. And I think that, sometimes age can definitely play a part, because as a young mom, I think part of me getting brushed off was the fact that I was a young mom. I was a first time mom. And so for her, she's sort of worried, almost to the point where, she was like, do you think you can really sort of participate, in my appointments going forward? Because she doesn't want to be seen as that naive, patient who doesn't know anything. And she's like, well, you can speak to these things, so much better. But the point is that they shouldn't have to be able to speak to these things so much better, right? Like, you should be able to get the same treatment regardless of if you know the lingo or if you don't know the lingo, or if you had a parent who knows the system, or if you never had a parent who was really able to navigate the system. So very, very interesting stuff, but I'm still in awe that she's 19. So Belen, I'm going to get this right. So you are actually our only panelist who is an adult living with CHD. And so can you speak, and you're also not from the United States, correct? Yeah. English is your second language. So you have a lot of things in your background that could have potentially caused issues in your care. And so can you just give us a little bit of your perspective as an adult with CHD, as someone who, did not grow up in this country and English was not your first language? how this has impacted your care throughout your experience with getting treated for CHD.
Well, first of all, thank you for inviting me. I'm very happy to be here. I was born in Venezuela back in the 60s. So, you know, when I was born, everybody is like, they didn't know, you know, what to do with me. So I had a doctor that knew some people in the Texas Children's Hospital. And that's why I ended up going there to have my surgery. I went back to Venezuela and I lived all my life there. I never encountered a lot of bad situations because the medical system in Venezuela is totally different than here in the United States. In Venezuela is that you either have money or so sorry for you. You can't, you know, there's nothing that you can do about it. And so, you know, all my, you know, when I was growing up and everything, one of the things that I could see is like, you know, the way I look and everything, because, you know, when you have I have the trichospia atresia. So, you know, your hands are purple and all that stuff. You know, people can be like kind of, you know, asking like bad questions, you know, like mean questions. But, you know, I always took it, you know, like, it, you know, I didn't care. And I think that one of the problems that I had, and I cannot blame my parents, but is that I didn't know about my condition. They told my parents when I went to Houston and I was 6 months old, and I have a shunt. I just had a punch shunt because I have a trichospia atresia. And, oh, she's okay, you know. So my parents, I never had another surgery. I never had anything else. So I lived all my life in Venezuela until I was 21, and I moved here. When I moved here, is that I had to, you know, it was another world because, you know, it was really hard for me to understand how, you know, the medical system works here. And yes, I encountered a lot of people that, you know, that they were like, I felt bad because, you know, they would ask me stuff that, you know, I didn't know. I said, well, I think that the only thing that I can do is have acknowledgement of my own condition so I can explain to the doctors how to, you know, to explain to them the way I feel. That's why I started, you know, with Adult Congenital Heart Association. I started, you know, to participate with them and all that stuff, and then with Conquering CHD, because it's like I was 30 and I didn't have a clue what I had. I knew that I had something different, and, you know, I had my heart condition and all that stuff, but, you know, I didn't know, you know, what I had. So that's why when you were talking about, you know, when your daughter is 18, I think that the most important thing is that, and this is very good in this new generation, they want to know what they have. And they really want to, you know, help themselves and advocate themselves for themselves. And I didn't have that opportunity. So, you know, when I went to doctors here, sometimes I felt like, you know, like I was like, no bully, but, you know, like, oh, you haven't have this, you haven't have that, you know, never heard about Glenn, never heard about Fontan. I never heard about that, you know. It's just, for me, it was like, it, you know, the doctor, it is, you know, sometimes when they try, thank God, you know, my husband is American. So for every appointment, he comes with me, because sometimes it still is hard for me. And that's why now I participate in all these, you know, like good things that you have had, because, you know, it's teaching me, and that I have to, you know, advocate for myself, that nobody's going to do it for me. So I think that, you know, of course you're always going to find challenges when you're not from this country. because there are people that still, you know, the implicit bias that you guys talking about, you know, and yes, we are very loud. You know, Latins are very loud, but I have learned that I have to, you know, don't be very loud. But when I'm talking to my family, my husband is, I'm leaving. I can't take it anymore. You know, very loud. But I think that, you know, this is the most important thing. And, you know, my transition from being a kid to be an adult, I think I became an adult here in this country. And this is why I love this country. Because in my home country, I was a little girl who had a heart defect and nobody could say anything to her. You know, I learned everything here. So yes, you can find it's difficult. And this is what I'm trying to do with my, you know, with the foundation that I have, is because, you know, trying to teach these mothers that, you know, they have to advocate, they have to do something for those kids. And I just think that, you know, if you have the knowledge and you know what you have, and I mean, you can really know the truth, which I think that it was a big mistake that they hide from me, you can do things better. And I think that that's why the new generation is doing much better, and they're going to go to adulthood in better than me.
Thank you, Bella. And that was, I appreciate that. And our goal is to get to the point where, regardless of if we are quiet or loud, that we can be quiet or loud in whatever setting we want to be, right? So I do have a couple of comments, and just because, you know, we were sort of talking about, you know, English as a second language, and, you know, how you've had your husband come to appointments with you to be sort of able to help with some of those things. So there's a comment that came in from the audience, and it says, I think it's important to discuss how some families are completely excluded from being able to participate in rounds because of language barriers, as translators are often not present. And people tell them they will come back and talk to you so that they are not able to or allowed to advocate for their children. But along those lines, there was another comment that came in from the audience, and I apologize, I'm reading this one from my phone. It says, I've gone to a new provider for my son only to find out that they had a translator waiting for me. They assumed I needed one due to our last name. Whenever I bring that up to people, I'm often told, well, we're trying to be helpful and proactive, but one person's helpful is another person's harmful. In this case, an expensive translator was wasted and not used on someone who actually needed it. Furthermore, I wonder what assumptions this office made about people who needed translators, and even what assumptions they will or have make about me. Best way to be helpful, be okay with asking and not assuming. So I actually just am gonna switch hats for a second because I was a bedside nurse for a while, and I definitely seen this play out in action, because sometimes people perceive needing a second person there to help facilitate a conversation as a nuisance, a barrier, you know, that 2 or 3 extra minutes, maybe they can't, you know, they can't spare. What I have witnessed directly, I was investigating an event, and something happened where there was not a translator at discharge, and it was an asthma patient, so not CHD, but still affected long-term care of that patient. Patient went home, and there was a significant misunderstanding about the dosage and how that asthma medication was supposed to be given. Patient showed back up into the ER a couple of days later with significant issues, to the point where they had to be put in the ICU for a couple of days. And so when we think about just those things that, you know, we have to come to a point where someone's long-term outcomes is worth more than those 2 or 3 minutes of what you consider, you know, of an inconvenience. And does it take a little bit longer? Yes, but does it have to derail, you know, get to the point where it derails someone's care? No. And so, but unfortunately, sometimes we don't think down the line, like, what does that small decision that you're making at the time, for whatever reason, actually, how does that impact, you know, a patient long-term? And so, but I do like this participant's comment with the fact that, you know, we have to be okay with asking, because she's right. We can't assume that everyone needs a translator, but we have to make sure we have the resources where we need the resources, and not make those assumptions. So I just wanted to sort of throw those in there while we were on those subjects. I know we're starting to run a little bit short on time, so I'm going to switch just a little bit, because there was a couple of questions that came in from the audience that I really want to make sure that we are able to get to. So one of the questions says, as a child welfare social worker, I think it is important to highlight that children of color are disproportionately overrepresented in the child welfare system, and the top category of mandated reporters who overreport for issues connected to poverty for children of color is healthcare professionals. And sorry, I just lost my place a little bit. Do the speakers have insight into the implicit bias that is present within healthcare providers that negatively impact these issues?
I'm sure that Tori has a ton to say about this, but I just want to say something as a provider first, because this makes me so crazy, this question, and we see it all the time. We as a healthcare system are too lazy about getting to the root of the social determinants of health. And so someone doesn't show up for care, and right away we're ready to make a phone call about medical neglect without understanding the actual concrete barriers. And I do think that the benefit of the doubt is given in a different way that is primarily based on our own intrinsic biases. And that is not a black or white thing. I mean, on the provider end, I think that happens to people of all backgrounds, that implicit bias exists, and it frames how we respond to a patient who, or a family who has missed 2 appointments or whatever it is. I think that I'm hoping that now there's an increased conversation about actually measuring some of these things and really addressing the underlying causes for the way that people come to care and the barriers to getting that care, because that's really, I think, where the issue is most of the time. And I don't think that we are good at that. We don't prioritize it the way that we should as healthcare providers. And all those individual factors are making a huge difference. And it's easier for us to make a phone call to child services than it is for us to get 3 more social workers to deal with what's actually going on.
Thank you. Tori, did you have anything to add to that? I know you have a lot of experience in this area.
Yeah, and I just wanted, like what you're saying too, because I live in Rockford, which is like 90 minutes outside of Chicago. So we had this hospital that touted to be like a new women's and children's hospital and brought all these specialists from Lurie's like into us, and then decided, you know, the state Medicaid's not paying. So during COVID, he just decided, we're just going to close the PICU. We're going to close and all the specialty. So now there's this whole like group of people in my area, which is, I mean, Rockford's not a small town. It's pretty big. That now we have to go to either Chicago, Milwaukee, or Madison for care. And like, for me, that's, as a foster parent, you know, I can afford to do that. Most of the time I can do those things. But I think for a lot of the parents, that transportation is an issue. Like I think in the previous panel, they had said, you know, when you're taking off work, or it was the first doctor I think that I saw speaking, like when you're taking off work, you're not going to be able to feed your family in order to drive all the way in for care. I don't think that should be called in as neglect, because that's a really tough position to be in, because you have to choose between your children. Like, and if your children, like, you know, Belen was saying, like, a lot of the parents are like, oh, they're okay right now. So you're going to choose the immediate need. And the immediate need is, I need to go to work because I need to feed this child. that's, you know what I'm saying? So like, I think, yeah, they call in a lot for that. I've brought in that social worker and asked, what can we do to help you? You could probably,
Yeah. Rebecca, I know it's 2:30. There are several more questions, so I want to see how you wanted me to handle that. Is this something that we maybe can get some answers to and send back out? Because there are several questions, and then plus I just wanted to at least have time to give people a chance to wrap up, to say, okay, what can we do in the next week, you know, or 2 weeks to help address this issue? So give me a little bit of guidance.
Yes, I can give you guys an additional 5 minutes to do your wrap up, and then absolutely I'll connect with you, Rita, and maybe we can put out a blog post or some other form of communication with the answers. That would be great. Questions. Absolutely. Go ahead.
Thank you. So we've discussed lots of different types of biases. We've discussed, you know, individual systems, all those good things, but I do want to give everybody a minute or two just to speak to what, you know, from your realm, what can be done on the immediate side. I mean, I know we have long-term things that might take some bigger lifts, but what are some of the small things that we can all start doing today in whatever space we work in to be able to address this issue and make it better?
Rita, I'd be happy to offer one thing that I practice that I think both providers and patients can do, is to look at the interaction as a partnership. So oftentimes I will talk with families as to how I may have expertise in clinical medicine, but you are the expert in your child. And so our objectives are shared. We want X as the outcome for your child. Here's what I can bring to that. What do you bring to that? And the same thing can happen from the patient family perspective. I mean, I am a parent and I have had to advocate on behalf of my child too, and say, you know, I know my child or I know myself. And so entering into these interactions as a partnership or framing it in that way sometimes can help eliminate some of the biases or assumptions that may be feeding into or affecting how healthcare is delivered. And from a patient standpoint, may seem a little bit more accessible than feeling like I need an advanced degree to speak up and advocate for myself.
Yeah. Anyone else have some input on that?
I just think that one of the most important things, you know, especially for us, you know, the ones that we don't speak English, you know, it's not our first language. If there is something you don't understand, it doesn't matter. Be honest, say it. Say that you don't understand. Or, you know, the providers and the doctors to be patient with us, because, you know, sometimes you can see when you talk or when you say something, even to try to explain the way you feel, it's like, you know, you can see that, but it's because it's that language barrier. And it's just, that's very important. And I used to be like very, you know, very shy about it, but now I'm not. You know, I take my husband everywhere with me because, you know, things have happened to me for misunderstanding, you know, about medicines and all that stuff. So that's the only advice in things that I can say.
I think that speaks to what I would say, which is how critically important it is to build trust between the health system and patients, between individual providers and patients. We have got to get to a point where people don't have to run around pretending to be sweet and polite all the time so that nobody's mad at them and they're not too pushy and they're not too angry. And that goes for patients and it goes for our colleagues at work. I'm not saying people should be yelling at each other, but like people need to be able to come into the hospital setting and be their authentic selves, because that provides additional perspectives that make us better. So if the parents are too afraid to tell us that they didn't like the way we delivered that care, we cannot make it better. The same is true for our colleagues who come from a different background, different perspective, who might see something about the care that we could modify that would work better for different types of families. So, but the only way for that to happen is you have to have enough trust in the environment and have an open an honest conversation with each other and be building that trust so people can say what they really think and be who they really are.
Thank you.
No, I think there's a lot of opportunities. Okay. Oh, sorry.
No, go ahead.
Yeah, I was just saying, I think there's a lot of opportunities for providers to look at their own practices and really identify the extent that implicit bias is affecting their care. And I think there's a lot of ways to do that. And I think just looking at your practice patterns with regards to tests you order, referrals, and things like that, and how that varies with age, gender, race, ethnicity. I think most providers will be very surprised about the extent that implicit bias really impacts the care that they provide. And that's the starting point, because then that provides sort of the next step would be opportunities to look at interventions to try to improve that care and provide better equity of care amongst all populations.
Thank you. I know we're short have run our time out, but thank you guys so much for all of your input today. And I definitely look forward to being able to get back to some of these questions in some sort of blog post. So for the audience, if we were not able to get to your question, I promise we will address it through a different means.
Absolutely. Thank you all. We're going to go to break, and it will be a 5-minute break. So we'll see you soon.
Thank you.
Thank you.